Welcome to the Department of Pediatrics and Neonatology. To our lesson, our lecture today will be about disease accompanied by hyperthermic syndrome in children, and diagnosis and comparative characteristics and treatment tactics. A definition of the problem is that fever is an non-specific human protective adaptive reaction developed in the process of evolution representing the organism's response to disease or other damage, which is characterized by an increase in body temperature. This variance of fevers depending on the degree of increase in body temperature distinguished on the follows four types. The first is subfebrile type, the fever no higher than 38 degrees Celsius. A moderate type between 38 and 39 degrees, and high between 39 and 41, and hyperthermic type more than 41 degrees Celsius. There are oftenly three places to measure body temperature in children, like an first axillary area, and rectal method, and inguinal folds. The etiology and pathogenesis of fever follows on first infectious process and non-infection process like hemorrhage in a brain and tumor, a brain edema, and sometimes of trauma. In fever, heat production increase and heat loss is limited. Fluctuations in body temperature during an infectious disease depend on the degree of progression or quiescence of the infectious process. The onset of fever, the primary, is the entry into the body of infections and some non-infectious pathological agents, as well as the formation in the body itself of substances that activate the phagocytic system of the body, release of biologically active substance, endogenous pyrogens, penetrating in the brain. Pyrogens contribute to the release of arachidonic acid, its metabolism into prostaglandins of group E, which increase body temperature in the thermostatic center, which located in hypothalamic area, which accordingly determines the clinical picture of fever. The diagnosis depends on careful collection of the child's medical and life history, determination of vaccination status, the duration of symptoms, concomitant manifestations, and excluding recent contact with infectious patients. The differential diagnosis in fever of unclear origin, it is necessary to exclude acute infections like typhoid disease, erythematosus, brucellosis, generalized chlamydia, and HIV infection, chronic infections like toxoplasmosis, chronic hepatitis, extrapulmonary forms of tuberculosis, various focal infection, malignant tumors, and autoimmune disease like systemic lupus erythematosus, systemic vasculitis, and periarteritis nodosa. The algorithm of action: first, we need to assess general condition and vital functions like consciousness, respiration, and blood circulation. Next, we need to make an objective examination to measure body temperature and heart rate and blood pressure, exclude the presence of meningeal signs, acute abdominal and As a pathologist, the signs of toxicosis, like painful appearance, refusal to drink, apathy, increased irritability, a difficulty in establishing eye contact, a prolongation of capillary refill time of the nail bed more than 2 seconds require exclusion of hyperbacteremia. Education for antipyretic therapy, a moderate fever in patients with epilepsy and oncological pathology, symptoms of increased intracranial and blood pressure, and heart defects, hydrocephalus, and other prognostically unfavorable risk factors. Next, and moderate fever in children of first 3 months of life, and moderate fever in children under 3 years of life with consciousness of perinatal CNS damage, especially in children with extremely low birth weight, and all causes of high fever, regardless of the child's age, and all causes of white fever. The red fever, it looks like the child's skin is hot, moist, moderately hyperemic, and no signs of centralized circulation. We need to use two pharmacological agents like acetaminophen or paracetamol in a single dose of 10 to 15 milligrams per kilogram orally or rectally, and ibuprofen in a single dose of 5 to 10 milligrams per kilogram, and physical methods of cooling. Repeated use of paracetamol and ibuprofen is possible not earlier than 4-5 hours after their first demonstration. In the case of impossibility of absence of paracetamol and ibuprofen, it is possible to use some kind of antipyretic mixture. If there are no effects after 30 to 40 to 60 minutes, a demonstration of antipyretic mixture can be repeated. In the case of impossibility to use, absence of paracetamol or other indications, it's possible to administer paracetamol at the rate of a single infusion dose for children from first year and older, and a dosage 15 milligrams per kilogram. The white fever, pronounced signs of centralization of blood circulation, the skin is pale with a marbled pattern and cyanotic tint of lips, fingertips, and extremities are cold. Cold sensations persist. Objectively, we could discover tachycardia, dyspnea, and other children delirium. In severe cases, with rapid increase in the level of endogenous pyrogens in the brain, we need to warn the child to use paracetamol or ibuprofen, and in the severe condition of the child, an impossibility of using intravenous drugs, intravenous injection of slow solution of paracetamol can be chosen. In the case of febrile convulsions, we need to provide fresh air or oxygen therapy and administer intravenous of diazepam solution at the rate of 0.1 milliliter per kilogram body weight, but no more than 2 milliliter at once. And there are some indication for inpatient hospitalization during fever syndrome. Ineffective use of 2 or more therapy regimes, ineffective use of starter therapy for white fever in children first year of life, a combination of stable fever and prognostically and favorable risk factors, a hemorrhagic rash on the background of fever as well as sleep disturbance, refusal to eat and drink, restlessness, tachycardia and dyspnea, and a fever with abdominal pain and vomiting. We need to exclude appendicitis and urinary tract infections. Thank you for your attention.